This is a study showing the duration of response using a Kaplan-Meier plot. 566 patients were treated with pregabalin, and this is patients who lose efficacy from placebo, and these are patients who lose efficacy while taking pregabalin. Right? So whenever you do a study, you end up with a placebo response. But it is a true fact that if you look at repeated dose studies that go on for weeks in the pain world, typically the placebo response wanes. Some patients have prolonged placebo responses that even go on for years, but most patients will have placebo response dissipate over a period of weeks. Just to give you a sense of this, in one of the early studies of amitriptyline, which we all know is an analgesic, in diabetic painful polyneuropathy, the investigator had the study go on for 6 weeks. And the primary endpoint was the difference between the placebo group and the amitriptyline group at the end, at 6 weeks. If he had chosen to stop the study at 5 weeks, the primary endpoint would have been negative. It would have been a negative trial. At 6 weeks, it was positive because enough patients lost their placebo effect between 5 and 6 weeks to make the difference between amitriptyline and placebo positive at 6 weeks. So the bottom line is whenever you do this kind of analysis, these analyses are not often done because we don't really have large enough numbers, but so many patients, there have been so many studies of Lyrica. You know, Pfizer has so much money, they don't know what to do with it, so they just do the same study over and over again. It's just amazing. But there have been so many studies of Lyrica that they were able to do this Kaplan-Meier plot and show that some patients with placebo do get effect, like I showed you before. Right? Some patients with placebo do get effect, but it tends to wane over time. Okay, so all these drugs, so a patient comes to you, they have chronic widespread pain, they're fatigued, they have migraine, they have IBS, pain in the face, and they have a sleep disorder. And you do an examination, series of blood tests, and you say, you know, you have no primary disease other than your pain syndrome, and your pain syndrome doesn't meet criteria for fibromyalgia, so we're going to call you chronic widespread pain, and we're going to note that the important clinical issues here for you are chronic widespread pain, insomnia, and chronic fatigue. Maybe migraine is there too, maybe IBS is there too, and you say how to go forward. And the best way of thinking about this is to go forward with both a pharmacologic and a non-pharmacological set of modalities. On the pharmacological side, depending on their comorbidities, you might consider an antidepressant, TCA, SSRI, SNRI. You might consider pregabalin or gabapentin. You might consider tramadol. You might consider Requip or one of the dopamine agonists. And all that is evidence-based. You probably don't want to put the person on Percocet because it's not evidence-based. And if you're going to pick an opioidergic drug to put the patient on, you give them tramadol because it is evidence-based. So a reasonable thing, for example, would be to give the patient duloxetine with tramadol as a rescue. That would be a very reasonable pharmacological response. Or to give the patient, if they have a very bad sleep problem, try amitriptyline, very small dose at night, start with 10 milligrams, then go up, and give them tramadol as a rescue. So there's lots of avenues with medicines. And then, of course, the non-pharmacological options have to be considered, and probably the most important one in terms of what's in the literature is exercise. There are randomized trials of exercise in chronic widespread pain that date back 25 years. And it's really remarkable that, physicians who see these patients sort of don't make this recommendation immediately as a matter of course. You tend to refer patients to physical therapy or talk about this sort of in passing. But exercise in these patients, and parenthetically also in CFS, in chronic fatigue syndrome also, which again suggests that there may be a common pathway there, but large muscle aerobic exercise. So what I've always done with these patients, so you see exercise reduces tender points and reduces pain. This is just one of the trials, right? So what I always do with these patients is to have them do a diary and to spend 10 minutes talking to them about exercise that's that's sub-threshold, that's sub-pain threshold. So they need to exercise large muscles. So that's probably walking or swimming as the two preferred modalities, or they can use an elliptical, or if they go to the gym, they could use a treadmill or a bicycle. But the idea is to exercise large muscles, and because there is a post-exercise flare syndrome, which again, parenthetically, both in fibromyalgia and in CFS, there has been a post-exercise flare of symptoms reported. So if there's a post-exercise flare, which can occur the following day, you don't want to push people and then have them crash and have a terrible set of days after this, right? So the way to do this is to have them literally start with 2 minutes of exercise and try to say, do this twice a day. I want you to go on the treadmill and walk for 2 minutes twice a day. And do that for a week. And then go to 4 minutes. And then show them how to use a diary and have them plan to bring the diary back so that you can encourage them and give them some modifications if they're able to move that forward. So exercise is actually really important in this disease. Also, CBT has been shown. There's a systematic review of CBT. Did not show benefit, but most practitioners of CBT say, well, you have to focus on specific things like adaptation or improved sleep or coping. If you just look at CBT and look at the usual parameters, the broad pain and fatigue parameters, it isn't a strong enough effect size to see a group difference. But most people believe that CBT is potentially useful. Exercise, no question. CBT, less evidence. Acupuncture did not work in 2 trials, so probably not worth talking about acupuncture. Okay, so the way to think about fibromyalgia is that it's a spectrum disorder like autism. So now we know we have chronic widespread pain, and some people will have fibromyalgia. The other way of thinking about it is as a common final pathway disorder, that it probably reflects a pathophysiology that's multiply determined. Multiple different disorders culminate in chronic widespread pain. Some of those, and so the final pathway is enhanced pain perception or lowered threshold, but the underlying factors may be predominantly genetic. They may be related to a neuroendocrine or neurochemical dysfunction that affects substance P or affects immune response. And at this point in time, all you know is that patients with chronic widespread pain or fibromyalgia have this lower threshold to nociceptive input or this enhanced response, but the underlying pathophysiology we don't know. In the longer term, going out years from now, the likelihood is that there'll be subtypes identified that will be treated differently. Irrespective of what you might think about the diagnosis, the goal is make the diagnosis of chronic widespread pain also highlight the comorbidities, CFS, major depression, IBS, migraine, interstitial cystitis, and then also the broad manifestations, insomnia, mood disturbance, whatever, as well as pain, and frame for the patient a therapeutic strategy that addresses multiple priorities. That's my view anyway. The typical approach is a multimodality approach that incorporates pharmacotherapy with one of the drugs or more than one of the drugs that's been evidence-based, plus exercise, plus psychological interventions if the patient can access those. Questions, comments? Who believes fibromyalgia is a disease? Okay. Good luck.